How about we do this? Next week's our last episode, and that makes today the Abby Singer. I want you to go look that up. Welcome back. Over the last few episodes, we've looked at the environment, either substances you may take, behaviors you may do, or people you may sit with. And we talked about how they interact with the genetics any individual person has to determine whether they're helpful or not so helpful to that person with addiction. And so we come to the genetics. And I'm really excited to get to this episode because it's the subject that I'm most involved in right now. Now, people have asked me lately, what are you doing professionally? And I haven't been talking much about it because I've started a genetic education company called Gen Ed Systems. And the first product is genetic education about addiction. The reason is I want everyone to be as sophisticated about the genetics of addiction as the doctors who worked with me at my treatment center were. We found it very helpful to be able to sequence people's medical treatment. And I want everyone to know as much about the genetics of addiction as I do and have the ability to get the testing that can make that education useful in their own life. But this isn't an ad. I will have some shameless promotion and a free offer at the end. But right now, let's get to what genetics can do for us around understanding addiction. Now, to start, we have to go back and remember what we already learned about addiction, that dopamine is important, dopamine tone and dopamine spike. Now, I'm only going to give you a short list because the whole list of all the genetics we could look at with addiction would fill far more time than we have in any individual video. In fact, it would probably be the same length of all the videos if you threw them together. But just for the few minutes we have today, let me go through this incomplete list. We're going to look first at dopamine production and then dopamine release. We have to look at production first because you can't release what you don't produce. After release, we're going to look at the dopamine that's available to the receptor. And you can't have it available to the receptor until you release it. So you can see there's an upstream to downstream movement. And you have to understand that or the genetics don't make any sense. Then we're going to talk about the genetics of the dopamine spike. And even though there's even more than dopamine tone and dopamine spike to look at in the genetics of addiction, we're going to just stop with that for today so that you get the idea of just how sophisticated medical treatment for addiction could be. Now, before we start, let me say something about using medicines for addiction. Everyone's talking about MAT, medication-assisted treatment. And when they say that, they generally just mean one or two different medicines for people who use opioids. It couldn't be anything further from how simple that is. Real medication-assisted addiction treatment is very sophisticated and requires a lot of training. And nothing I'm going to say today means you should run out and talk your internist into giving you a particular medicine. In fact, I'm going to refrain from mentioning any of the medicines by name, if I can remember not to, just so nobody's tempted to do that. So let's start with dopamine production. So there's an important gene in the ventral tegmental area cells called MTHFR, and it turns the folate you eat in your diet into L-methylfolate, which is the only form of folate that your brain can use to make dopamine. If you don't have enough MTHFR activity, then you don't have enough L-methylfolate and you don't have enough dopamine. The good news is that people can take L-methylfolate as an oral supplement. And so knowing whether you are deficient in enzyme activity at MTHFR is very important. Here's an example of just how important it is. When we first started doing genetic testing at my treatment company, we didn't have the fast response time we have today. We used an outside lab that took 6 to 8 weeks to get the answer back to us. So patients were finished the intensive outpatient program by the time we actually found out their genetic testing results. Some people wanted to take the L-methylfolate we talked about, even though they didn't know the answer to their test. Other people said, no, I don't want to because my insurance won't pay for it and I don't want to spend the money. So we had, in essence, a naturalistic experiment. We were blind to what the results were going to be, and some people took the L-methylfolate and some didn't. Here's what we found in retrospect. Of all the patients who didn't need L-methylfolate, that their genetic testing was fine for MTHFR, 100% finished the intensive outpatient program. For the patients who did need L-methylfolate by genetic testing, but happened not to take it, 11% finished the intensive outpatient program. And of the people who needed L-methylfolate and happened to take it, 80% finished the intensive outpatient program. That's the kind of power you can get just from one of these genetic test results. Now, let's move on to dopamine release. There are many things we could look at that affect the dopamine release from the ventral tegmental area, but just for this example, we're going to look at two. There is commonly called the nicotine receptor. Scientifically, it's got another name, but we'll just call it the nicotine receptor. If you have a specific mutation at the nicotine receptor, you don't see the brain's chemical that usually acts at that, and so you don't release enough dopamine. But of course, if you started taking nicotine by smoke, it would work and you would get enough dopamine for a very short period of time. Well, there's a specific medicine that if a doctor knew there was this problem, they could use to counter it so that your dopamine release from the ventral tegmental area could be smooth and have a higher tone. There's also a specific mutation of a specific serotonin receptor on the ventral tegmental area that, if turned on by serotonin, actually lowers dopamine release. Now, knowing that you're sensitive there is very important because a lot of people with addiction who see a doctor who doesn't know a lot about addiction get misdiagnosed as having depression and get started on a serotonin medicine that actually lowers dopamine tone when they already started with a lowered tone. A lot of people start such a medicine and feel great right away, and a few months later, it's as if my depression is back. The doctor raises the dose, and a few months later, my depression is back. The doctor raises the dose, and a few weeks later, my depression is back. I've literally met hundreds of people with that story, and often they ended up coming to me when they were ready to just check out because they were convinced they were untreatable. They'd all had smart doctors who gave them medicines that made them feel better right away. They thought they were untreatable. That's not actually a problem with the patient. That's a known side effect of serotonin medicines in people with this genetic mutation. So it's really important to know about it if you're going to be treating people with addiction. So let's say now we've got good production and good release, and the dopamine is coming out into the synapse and it's available to be seen by the dopamine receptor. Once the dopamine is released, it then has to sit at the dopamine receptor for a certain length of time for the signal to get through. Now, we all have a vacuum cleaner called the dopamine reuptake pump that sucks the dopamine back up. And there are specific mutations of that pump that make it work overtime so that the dopamine doesn't have enough time at the receptor for the signal to go through. If a doctor knew this, they could give a medication that blocked that pump, giving the dopamine the time to get the signal through. Now remember, there's also dopamine spike. There's a particular mutation of our opioid receptor that when someone takes alcohol, they get a very big exaggerated dopamine spike. Doesn't matter whether they're low tone or high tone, they get a bigger release of dopamine from taking alcohol. If a person has addiction involving alcohol, that's a pretty important mutation to know about. There's also a very interesting mutation of the dopamine receptor that affects your dopamine spike, because that dopamine receptor actually has two subtypes, a long and a short. The long sees the signal and turns it into dopamine tone, and the short is over on the ventral tegmental area cell where it sees the dopamine being released and says, okay, you've released some, knock it off. With this mutation, you don't make enough of that short receptor, and so you have a very high spike. Now, normally, when we treat a patient with a low dopamine tone and a high spike, as we raise the tone, the spike comes down. But in someone with this mutation, as we raise the tone, the spike stays big. Now, this is important because if we know this ahead of time, we can blunt the spike before we raise tone and avoid some of the problems of side effects of medication. Now, this is a very incomplete list. I just wanted to give you a taste of just how sophisticated medical treatment for addiction could be if we understood addiction as a brain illness that was primary and largely genetic. We all know that right now, almost all the argument about medicines and addiction are surrounding one or two medicines for people with addiction involving opioids. That's really not even the tip of the iceberg. It's a penguin on an iceberg. The real question of medications is so much bigger, so much more sophisticated. And I want everyone to be able to have information about that. So here's the offer we're going to end with. If you subscribe to this Ending Addiction channel, comment on this video, and a week after the video is released, I will take all the commenters' names, throw them into a hat, and 5 will get a free Gen Ed individualized genetic report for addiction education. That's all you have to do. Be a subscriber and comment on the video. Now, with this episode, we've brought you up to date to where we are today in the most sophisticated we can make addiction treatment in order to end addiction as a problem. But the future holds even brighter potential. Next time, we're going to talk about some of the things that we're all going to see coming into addiction treatment over the next 5 to 10 years. And after that, we're going to wrap up Season 1 of Ending Addiction. I hope you join me. Until then, be well.